Aye.
Opposed? Motion carries.
New staff for provisional active is Michael Nequio, who is in ophthalmology, will be joining Dr. Chahetsky.
Move appointment. Second.
Okay, we have a motion and a second to approve the active staff appointment of Dr. Nequio, is it?
Nequio.
Nequio, in ophthalmology. All those in favor?
Aye.
Opposed? Motion carries.
For provisional courtesy new appointments, Nahir Gandavati in cardiology, Feng Wang in cardiology, and Hillary Shaw in radiology.
Move approval of courtesy staff appointments. Second.
We have a motion and a second to approve the courtesy staff appointments as read. All those in favor?
Aye.
Opposed? Motion carries.
For our advanced clinical practitioners, these are the reappointments. Hannah Carlson, ARMP at the Rural Health Clinic, Ellen Jackas in internal medicine, and Irene Cure in internal medicine.
Move appointment of advanced clinical practitioner.
I have a motion and a second to approve the advanced clinical practitioner reappointments. All those in favor?
Aye.
Opposed? Motion carries.
And then we have one provisional advanced clinical practitioner new appointment, and that is Paul Cornett, CRNA with Navy anesthesia.
Move appointment of advanced clinical practitioner. Second.
We have a motion and a second to approve the advanced clinical practitioner, Paul Cornett. All those in favor? Opposed? Motion carries. Is it difficult keeping track of all the Navy personnel coming and going?
No, actually, it's Molly. Well, Molly's back.
Molly's back.
Molly's done a really good job of keeping track of everybody, and she's got some help from other departments, but so it hasn't been too bad. So,
I know they're fluid.
They are very fluid.
Yeah. Thank you.
Resignations: Jennifer Chu, internal medicine; Amy Pico, Tom Harris, and Timothy Hall. All submitted their resignations this last month. So, the only other business item, medical staff policy that we had talked about before, admission and discharge of patients. It's in your packet under subsection A. We made that language match what the hospital's language in their policy is. It should be on the back. You guys have it?
It's not
Yes.
I had a question under section A.
Yes.
I want you to define age handicap. I want to know if this handicap applies to me.
I believe there should be a caution.
I was hopeful. So far, I haven't found my age to be a handicap, but you know,
That's
you're the
good.
doctor.
We'll
The
talk
other
after.
thing, it says, under C, it says a physician or NPP member. What is NPP?
That is now the advanced clinical practitioner term. It was the term non-physician practitioner. We've now changed our new bylaws to advanced clinical practitioner. That's just a leftover term that we can update.
So in order for this to go into medical staff policy, we need a motion.
I move that we adopt the medical staff policy on admission and discharge of patients as amended.
The comma between age and handicap.
Yes.
I'll second that.
Okay, we have a motion and a second to approve the medical staff policy on admission and discharge of patients as amended. Is there any further discussion? All those in favor?
Aye.
Opposed? Motion carries. I was glad to see that you updated that.
Yes. As far as providers, we have lost a couple of general surgeons and orthopedic surgeons. Those vacancies are filled currently with temporary providers while we locate new staff. So there are still 3 general surgeons and 3 orthopedic surgeons on staff at all time. There are interviews set up with permanent people for both general surgery and orthopedics, which we hope to have filled within the next few months. As you guys know, doctors take a while to change jobs. It's not to give a 30-day notice and move on, or a 2-week notice. So these do take time, which we do use interim providers for, but those clinics are fully staffed. They will run as they ran before. There won't be any change to the public other than some new friendly faces. So there's no gap in coverage there. We're fully staffed, they're taking call, they're participating in clinics, and doing a great job so far. The impact of Navy closing their doors, you know, it's hard to say the Obamacare, for lack of a better term, occurred at the same time, which meant that more people had insurance, which meant that more people were seeking care at that time as well. So we have had an increase in Navy people, but we've also had an increase in people who didn't have anywhere else to go and didn't seek care because they were concerned about bills and things like that. So it's good to see that we're capturing those people now as well, and that we're able to help them, and that they're not so concerned with, you know, what's this treatment going to cost me, and can I afford this? And it's nice to see them actually getting the care they need. So yes, Navy's had an impact, but so has the Affordable Care Act. And overall, the staff has done really well. We've changed nursing staffing a little bit. Doctors, physician staffing in the emergency department's been upstaffed as well. Our door-to-doc times are still among the best in the state, at about 22 minutes to wait to see a provider on median time. Doesn't mean there's not times it's longer, but overall, and you'll see that on your dashboard. But overall, we have had an increase in volume, which has been good for us. And good for the community that we're able to see more people. So if you look at it, we see about, population-wise, if there's 65,000 on the island, and we see 22,000, so 1 out of every 3 people a year. So overall, everybody's done a great job, and yes, it's impacting us, but impacting us in a good way.
So when they present in the emergency room, how do you try to connect them with primary care for future care?
We do. The clinics, as you know, are backed up currently, and they're looking at ways to open up more space in the clinics and open up new providers and find ways to fit more of the island into the group. If there is an urgent follow-up need by our medical staff bylaws, we can't assign a provider to take care of them until that problem is resolved. So regardless of their ability to pay, they still will get follow-up for that problem if it's an urgent problem that needs addressing. So.
And I don't know, Dr. Hansen, you know that the Navy's getting ready to pretty much gut their hospital.
Yeah.
And it's being run out of Army, out of Huntsville, Alabama, so it should be interesting. But they're going to pretty much gut it.
And we've met with OB and the Navy already, talking about some planning for when that happens, since our OB volume will increase.
And their 2-year plan will probably take 4 years.
And that'll affect our inpatient ability, because those OB patients come as inpatients. If we can only have 25, that's going to impact our ability to care people. So we met with Navy OB, we talked with Linda, and we'll talk to the state as well about a potential exception during that time, where we can take over 25 patients for assignment.
The exception being OB.
The exception being the amount of inpatients you can have in the hospital at a time.
And it doesn't have to be specific OB related.
I don't know, Linda might know that better than I. But that's something that is kind of long off in the planning.
Okay.
But we want to make sure that we have the capacity to, you know, still care for everybody on the island while Navy redoes their OB and does their hospital living. So we're actively working on it.
Is there anything else for Dr. Hansen? Thank you very much. I have to say that the last medical staff meeting I attended was probably one of the best medical staff meetings that I have attended since I've been on the board. It's nice to see everyone is working toward the same goal. It's very cordial and good, and really good sharing of information.
Yeah.
So I appreciate your leadership.
Thank you. It's a good staff.
It is a really good staff. move on to item number 7. Jerry.
Good morning,
Administrator's
everybody.
report.
I'm going to try to see if I've missed anything. You can jump back in, but let me try to answer as many of your questions as I can. First of all, I do want to comment, though. It's very rare that an administrator starts a job and has the opportunity to have 3 DOH surveys within the first 45 days. However, I looked at that as a terrific opportunity to consider this a unpaid consulting engagement. Because normally, a new administrator might come in and pay outside resources to come in and help assess an organization. And here we had 3 different outstanding teams from our state come in and basically ask us to open our doors and roll back everything we could to show them what we were doing well and what we were not doing well. As Linda cited, we did get approval on our annual survey, which is awesome. We do have some opportunities to fix a few things, and I'll give you an example. Probably when this building was built, all exits didn't have paved access outside doors where a potential patient might exit. So one of the things we need to work on is looking at those places we actually notate that patients will definitively exit from, and if there's grass there now, we have to go back in and pave it between the exit and the street. So those are some of the types of things they look at. They went through extensive patient records and patient documentation. They look at policies and procedures. I would tell you here, just as in many hospitals I've been in and consulted in, our policies and procedures have some work to be done. It's not that they're not done, they're just not as current as they need to be, and that's not uncommon. We've asked staff to now go through their policies and procedures, and if there's anything in their department-specific policies and procedures that are redundant, that are also listed in hospital-wide policies and procedures, they can clean those out. So for example, in another institution that I was responsible for, in one large department, they started with 165 policies and procedures, and when they really cross-referenced them to hospital-wide policies and procedures, the department's procedures dropped in the low 80s. So again, that's always continuous work, but that's how we want to run our organization, to be as current and compliant as possible. Compliance issues, I will tell you, I have seen nothing in my pre-assessment of this hospital and in the approximately 50 days I've been here that suggests to me in no way whatsoever do we not comply with all federal and state laws for what we submit on a financial basis. We are timely, we are comprehensive, we use outside organizations to make sure that we're being transparent. They're all vetted, and organizations used by many, many small and large hospitals throughout the United States. So I'm extremely comfortable that the information that we do submit is extremely within the limits of the law. Public meetings, a comment about that, yes, I am planning to have public meetings. As you know, Trish Rose has just returned from duty at the Pentagon, and she's my point person for helping set that up. And Trish and I have actually had one initial meeting to discuss that. My goal was to start that work post my 90-day assessment, but since that'll fall in the middle of the summer when many of our citizens may be visiting family, traveling for vacations, we decided that we would start those meetings in September to give a broader opportunity for residents that live here year-round to be able to attend. But as you know, and I've met with Mr. Bourne personally, I am more than delighted to meet with anybody on an individual basis at any time. So Dr. Wagner, one of the things I'd like to suggest to you is if we could possibly meet face-to-face, if we could set up some time together.
Your secretary already did that.
Excellent. So she's doing her job. I'd like to delineate your questions very specifically so I can make sure I answer them, or we answer them as appropriately as possible. We do get a lot of requests for public information. We follow the regulatory guidelines on that. However, because we're a public hospital, we are in a position where we have to have the requester pay for the copies being made. So we are very judicious about letting people know that if what they're asking for is going to rake up a $50, $100, $200 fee to them, we don't want to do all those copies and then have them be surprised. Also, sometimes the requests for information, and I'm not speaking exclusively to your request, sir, but sometimes the public asks for things in different ways, and they're asking for the same thing again and again, and we don't want to overcreate things both for them and for staff. Because again, we're pulling staff away from their everyday duties to create this information. We don't have a department that just is exclusively there to respond to those requests. We're using people that have other full-time jobs to meet those obligations. Meeting with the commander of the base, that meeting is set up, and I haven't verified exactly when, but Bobby, when am I meeting with the commander? In July. And he and I have been going back and forth by email since actually before I even crossed the threshold of this campus, talking about how we can work more in alignment with each other's needs, objectives, strategies, etc. But this will be my first time spending time with him face-to-face, other than some brief time we spent together at the holiday parade. The dashboard is being posted on the website, and that work is in progress, so plan to see that soon. Dr. Hansen did a great job explaining what we're doing with our physician replacement plan. I think one lesson learned in healthcare is that when you hire physicians, it's always good to look at a retention strategy, which also includes an exit strategy, that several physicians' contracts don't expire at the same time. So one of the reasons this has become, I think, a bigger event than it needed to be is when we hired all these doctors, we gave them all a common anniversary date of when their contract obligations expired, and that creates a void. So that's the strategy that I've been working with medical staff office on to discuss.
I'm glad to hear that, because, you know, we only maintain oversight, so we're not involved in the day-to-day contracts. So as a board, we were not aware that everyone's contracts expired at the same time. So I am really glad that you're looking at rolling expiration dates.
And I'm sure it was coincidental, there was no
They
harm,
all
no
came
foul.
on at the same time. Yeah.
And because we're an island, and because we have military spouses, and because healthcare is changing on a daily basis, if not an hourly basis, physicians do not come to a community and stay for a lifetime the way they used to. In the course of my career, I remember that, you know, docs used to come to a hospital and they planted their roots and they stayed there till they retired. But it is not uncommon at all in the United States, just like in many other fields, people change jobs. And I think you see that in other industries. Healthcare is no different. Culturally, there's different expectations now in the workforce, and that's something as leadership we just have to plan for. It's terrific if we get physicians that want to come here as a young career physician and spend their entire careers here, but I just don't think we can count on that the way we could have 20, 30, 40 years ago. And that's nothing to do with how we run our hospital or our community needs. It's just the culture of the way the medical community operates at this time. I've been working very closely with the physician offices and clinics. We have a lot of opportunities to work more closely with our physicians, and that was one of my primary goals and objectives, and I think Dr. Hansen has spoken to that. One of the reasons I've probably not been in the community as much as I would like to be, although I think I've been in the community quite a bit, is I've been spending a lot of one-on-one face time with the physicians, because the physicians are really a key member of our team. You know, hospitals would not exist without physicians, and our physicians need to understand administration, the board, the medical staff leadership, our goals and our objectives, so that we can all walk in step. We have a variety of businesses here, but the reality is we're no different than a big fleet of ships. And whether it's hospice, whether it's the hospital, whether it's the physician's offices, those are just individual boats in this fleet of ships, and we have to make sure we have good leaders on each of those boats so that the fleet can all be moving in the same direction. And that is a huge challenge in healthcare, and that will continue to be a challenge. And that's something that is going to be very important for Dr. Hansen and I to work closely with our physicians, because we do have office managers in our offices, but as you know, and Dr. Wagner being a physician, you know, the true leadership we need at each physician practice is our physician leaders. Full administrative team. Very excited to say next week our new CFO, Ron Tellis, will begin with us. He's coming with lots of experience in critical access hospitals. He's familiar with our electronic record and our electronic auditing information. So as far as our computer goes, so I'm very excited that he will not have a steep learning curve to work with Meditech, which was one of the criteria I was looking for. He's also someone who will be reaching outside the walls of his hospital, and as the board knows, I am going to be building an administrative team that doesn't only spend their time inside the four walls of this hospital, because we're here to serve a community. And one of the characteristics I was looking for are leaders that want to spend time helping me reach the community and find out the needs of the community, so that as we create our next strategic plan, which will be fairly shortly, we have to begin that work, we have as much what I call voice of the customer as possible. Where do people go for care? I think the comments made here, Dr. Wagner, were these are the people that we are serving that choose to come here. There are many people that we don't serve because they do not choose to come here. Data-wise, the way the data is collected by our government, we have very good inpatient data that's available to us. That's aggregated data, it's public data, but we don't have a good collection vehicle for outpatient data, not only here, anywhere in the United States. And as healthcare is going more and more outpatient, and I'm sure you've heard that spoken before here, but I will reiterate it, we are moving away from inpatient care to a world of outpatient care. Only the highest, most complex patients will be in the hospital, and that's being driven by our payers, our insurance companies, with the restrictions they give us by criteria. It's in the old days, we could admit just about anybody we wanted as long as the doctor said, I want that patient admitted. That's not how healthcare works anymore. We have Milliman data, we have other criteria that is given to us, and if patients don't meet this, we will admit them, but by law, we're obligated to say to them, if your insurance company is not allowing you for this admission, if you come in for this admission, it's going to be out of pocket. And of course, the majority of people are not in a situation where they can pay the cost of a hospital admission. So Dr. Hansen, you may want to speak to that again, but one of the things we do well here is we give every patient that comes to the emergency room an opportunity to find a primary care physician if they don't already have one. And that's called being associated with a medical home. And where healthcare has gone is because it's so outpatient driven, it's very important for every citizen on this island to be associated with a primary care office, to be having an established medical home. The significance of that is when they do become ill, whether it's a minor illness such as the flu or a major illness such as a heart attack, they already have a physician advocate that already knows them and knows their health needs well. It gives us as hospitals the opportunity to go back to that medical home, get baseline data and information so that we can treat them appropriately and as expeditiously as we can on the inpatient side. Comments on that?
No, I mean, that's exactly correct, and, you know, not everybody has a primary care doc, and not everybody will, but we do make efforts to try to connect people to the clinics and to try to open up space in the clinics to get them seen and followed up. So, you know, we try to help anybody that we can, and from an ER standpoint, you've already heard it, you know, we see everybody regardless of ability to pay. If you walk through the door and you seek care, we're going to see you and we're going to treat you just like anybody else.
And the other comment about information requested, I know, because I was copied on some of those emails, there were a lot of iterations going back and forth. We tried to not maximize our window of what's regulatory guidelines, but we do have guidelines for response time. But some of this information, again, that may be asked for is just not at our fingertips. We're not as, although we're computerized, we're not as computerized as you think we might be, and a lot of the information you've asked for is actually in files, in file boxes, in storage that has to be found, brought back to the campus, gone through, copies need to be made, etc. So I apologize if we didn't explain that process to you adequately. Is there anything I missed? Mr. Moore, were there any of your questions I missed, sir?
No.
Dr. Wagner?
No, I think that the accounting department can answer the remaining ones.
Thank you. The only other thing I'd like to share is I'd really like to compliment our staff. You know, hospitals are their own community, and our community here made a contribution and a commitment to Relay for Life. I'd like to take this time for the board to recognize Jenny, who was one of our co-leaders on that initiative. And our staff did a great job spending time, doing bake sales, raising money in a variety of ways, and we did not only meet our goal as a hospital, but we exceeded it. So kudos to the team.
Excellent. like the board to know that we have a very small hospital guild, one left on the island. One thing that the hospital guild is doing for all the holidays, they're making tray cards for the patient trays when their food arrives to them. So they'll be doing 4th of July, I know, and I'm thinking they're doing Father's Day. I didn't really make a note of that, but it's nice, and I guess it's been very, very well received. It's a group of volunteers and just a lovely idea. So I wanted to let you know that they're doing that. And it kind of tied in with some of the things that Jerry had on her report. Jennifer, welcome to the board meeting. You are up for your financial report.
First of all, I'll just say I'm Jennifer Reed, and I'm accounting manager, interim director of accounting until Ron gets here in a few days.
She was so kind to take this and so happy with the short window of opportunity.
Yes, so I'll work really hard to try to bridge that gap until he gets here, but I will welcome him when he comes. So the first thing on our financial and the income statement that I'd really like to point out is that we finally crossed the bridge to a net operating profit in April. And we're just closing May, but I can feel pretty confident that it's going to keep going the same way. We made a commitment to the board to be very conservative and to try to cover all the bases, which is why you see the cash balance go down a little bit, is because we've been moving money to cover all sorts of things, the bond payments. So we're moving those away from operating cash so it's available when the time comes. Pardon? Yes. So let me see. The expenses are, if you notice that, a 0% variance from budget. And the reason that we have a profit is more the revenue side, and we've been capturing charges, I'd say a little better, some price increases, which are accounting for a good bottom line there. So I think I'm going to make sure that I'm answering your questions here. So, about the bond payments, and you see net liability for bond payments. When you look at that and you say, how much debt do we really have? And you'll see for the bonds is $63 million, $380,000 plus some short term. Those payments that you're talking about are payments on that money, and we pay principal and interest. We accrue the interest, you'll see there, and then we have to pay on June 1st and December 1st principal payments. So that's what you see there on the current liabilities, and the liabilities towards the bond interest payable, and the current portion of your long-term debt. Those together make up the bonds. So when you get a bond, you actually borrow the whole bond amount from a company, and then you pay payments with your tax revenues coming in. So we use the tax revenues to make those payments.
Yeah, my question was from February to March, it went up 260,000. Is that happen every month?
Right.
Okay.
Right. Between the New Wing bond, and then we have two other bonds, 260,000 accrues to pay those payments. So hopefully that answers your how much debt do you really have for the bond. $63,380,000 for all three bonds total. You answered the zip code question. And you answered the emergency room question. The other question you had was about the third-party settlements. What that is the way we get paid as a critical access hospital is different than just sending out your charges and getting paid. So while we do send out our charges and get paid by Medicare and Medicaid, at the end of the year, we do a cost report, and then they pay us based on our cost. So what we've done here is, again, try to be very conservative and say, we think we might owe money at the end of the year because of how the charges have come through. But I'd like to tell you that we did just get our cost report back, and $600,000 of that $1 million is actually 400 is Medicaid, which we're still waiting for settlement. They're about 2 years behind, so we'll accrue 2 years of, do we think we owe them or do we think they owe us? And so that is from Medicaid. 200,000 is from that we thought we were going to owe Medicare, and it actually turns out that they'll be paying us back. So in order to stay conservative, we left those numbers there until the cost report is audited by Medicare. But it looks pretty good. So, and then the other 400,000 is money that we think we're going to owe Medicare and Medicaid from 2015. So just watching it along the way. We have a new allowance calculation that helps us really see where we are on a quarterly basis. So that will change a little bit at the quarter. But again, we wanted to be conservative and say, well, if we owe money, we want to know we're going to owe money. And this is one thing I think that Frank has really done a really good job of while he was here, is taking a look at that stuff and the cost report and how do we really get paid, and getting a better handle, I think, on that piece of the puzzle, which has helped the bottom line a lot. So I don't know if that answers everything.
Well, just one question for you.
Uh-huh.
As you stated that last month you were in the black, okay, but there's a significant amount of liability in the red still. How
Right.
long do you, if things continue to go the way they are now, what do you project? How many years do you think it's going to take to balance your budget?
To pay off the bonds?
No, forget the bond. The bond is going to be there forever, and it's going to cost $100 million. I'm
Okay,
talking about
I-
your. I'm talking.
I'm
excuse
sorry,
me.
Dr. Wagner, I appreciate your comments greatly, but we're out of the public comment section.
Well, she
So-
offered me the opportunity to speak
For
to
the
her.
questions that you had already asked, so.
And this is the same question,
Sir,
so it's nothing new.
Sir, we're outside of the public comment section. This is a public board meeting, and I'm sorry you're rolling your eyes, but we
I
have one
always do with
area
you,
for public
yes.
comment. It's not conversational, so if there's something that we've left out, let us know and we'll address it at the next board meeting. We'd be very happy to answer your question. Thank you. Would you like to continue with your financial report?
Well, I think
I think you're.
unless you have questions.
Go ahead. This is really an excellent report, and I think that our progress during 2015 has really been remarkable. These are, as Jennifer pointed out, these are accrual statements, which means that we have money put away for everything we know will happen and everything we think possibly could happen, so that we're not going to be caught unawares. And and that includes depreciation, which of course is a non-cash item. So this is not a cash flow statement. This is an accrual of everything that we know will happen and we think could happen. It's because of the way Medicare and Medicaid reimbursements work, it's very hard to pin down what we think is going to happen. And in the past, we've been caught short, and so the board had asked that this accrual be very conservative, so let's make it as bad as we think it can be, so we're not going to get slapped up against the side of the head again. So that's the purpose of these. But having said that, having accrued everything that can possibly happen, including depreciation, which is a non-cash item, all of these things, we showed a profit. We showed a profit. And we do not aspire to be like Peace Health and make $84,000 profit in the year. We aspire to break even. We aspire to provide services at only the cost that the services that we experience. So we're truly nonprofit. We're trying to put everything back into the program. So, and that breaking even is our goal. Having a profit gives us a little bit of extra space. But I think that we really need to look at staff, because staff, this is 4 months into the year that we have reporting on, and our expenses are exactly what we budgeted for. And that shows remarkable attention by the staff, because services go up and down depending on how many people come in our doors. But throughout that, they're really controlling the costs, which is a huge benefit to us all. The finances for a hospital like ours are always going to be up and down, because we don't know how many people are going to come. We can't make everybody on Whidbey Island use our services, nor do we turn away people who come to use our services who don't live on Whidbey Island. What we say is we offer service to anybody that walks in the door, and we will continue to do that at the least possible cost for the best possible service. And I think that our finances are really reflecting an excellent job. We went through a terrible time the last couple of years because of all the additional costs that we had to bear. And you know, when you go out and buy a new car, or you buy a new house, or you buy a new refrigerator like I'm going to have to do today, you know, a lot of times you don't do it out of pocket. A lot of times you finance it. But we did it out of pocket, and we paid a lot of money for it, and it affected our bottom line. But now we have it, we're in compliance with the new requirements, and we're moving forward, with a good, solid bottom line. There have been questions about the budget, because we're required to turn in a legal budget far in advance of the end of the year. So we turned in a legal budget, I don't remember, what month is it we have to turn it in? November. So they're getting it ready starting in September. And you know, when you turn in a legal budget, you want to be really conservative, and we didn't have any real good information even about what the end of the year was going to be like for 2014 when we turned in that legal budget. But the budget that we use for our financial statements, our operating budget, is right there on the financial statements, and it shows per month and year to date what we have budgeted. And that's what we're marking our progress against as we get these financial reports month to month. So I say bravo to staff for keeping the expenses under control, and I think that we are really looking good, and I think we've turned the corner. And the more we're able to stay on this track, the more additional services we'll be able to provide. So that's good news for everybody. So we appreciate you coming to talk to us too.
Services and equipment, so thank you. Thank you very much. We're going to move on to, I think Jerry's going to introduce them. We're going to move on to item number C, resolutions 356 and 357. Jerry, did you want to introduce them? Or shall we just take it?
Just take it, please.
Okay.
We have a couple of resolutions that deal with position titles that have to be done anytime we have a change in personnel. We are required to have a treasurer, and we're required to have an auditor. The resolution 356 deals with appointing Ron Tellis, and 357 appoints Jennifer, and Jennifer is the treasurer and Ron is the auditor. So these are housekeeping items where we're just simply changing some names to go with these two positions. So I move approval of resolutions 356 and 357.
Second motion.
Okay, we have a motion and a second to approve resolutions 356 and 357. Are there any questions? No? Okay, all those in favor?
Aye.
Opposed? I'm glad to have the housekeeping done in a timely manner. Mr. Wallen, would you like to give us some updating on the construction?
Just for everybody to understand, that once we passed the bond, then we had to do the whole process of coming up with hiring architects, contractors and all that, and then all the plans, all the investigations. So we have spent a lot of time getting to that point. We now are prepared, towards the end of June here, we'll be going back in front of the historical committee here in Coopville. So hopefully we'll get that. We went through it the first time, came back, and now we're going through hopefully on our final. And once we have that, then we should be in line to get our permits to actually start breaking ground. We've had to do a lot of investigative work around here. We've had to look at all the water lines. Coopville did not have as-built pretty much of water lines, sewer lines, all the undergrounds that are on the property here. So we've had to go back and relocate. If you notice, we went down and did some clearing down below. We had to chase the water lines down way down below and find all the connections. And so I think we too are very impressed with Jerry. She has done a great job of catching on and understanding the construction project. But I think Mark Estabel and I talk every day of the week, and sometimes on the weekends. We have emails going back and forth and trying to get to that point. I think we've made a lot of good progress. We're taking a relook at the interior. You know, the main thing is we want to break ground. We have the design of all the parking, kind of some major changes there. We want to break ground and start this summer with the parking lots, which we have to be built before we can actually do the construction. So that's our goal. Hopefully here by the 1st of July, then we'll be out on the road, out with packages for getting bids for all the earthwork here and the structural part. We do want to take a look at the interior finishes again. A lot of times, you kind of move forward rapidly, trying to get to that point, but we really need to take another look at that. So, and everything, we have to resolve every bit of wiring, how we're heating the place, try to be very energy efficient. Like I said, there's meetings every week, so we've been going to updates. So like I said, I really like the fact that Jerry has gotten involved. So Mark and I make sure we courtesy copy back and forth so she knows what's going on. There's a great communications going on between the whole group. Hopefully we'll be breaking ground this summer and get the gold shovels out, get it made, but we're getting close.
It is, just sitting back watching it, it's a lengthy process.
Oh, yeah.
Lots of details. And I know that you've met with the city several times, and now you're moving on the Historical Society to get all of your permits and make sure that we're in compliance with Historical Committee.
Yeah, we're having to get a TV camera set up through some of the pipes to locate where the sewer lines go for the city. So just an ongoing process.
So we'll, once, that's the 24th of June, is that right? And once that's goes through and assuming that it's approved, then we can expect to see beginning of groundbreaking, or are there other?
We have to get the permits. So we've applied for those. That's going through the process. The historical basically just gives you kind of permission. They don't issue permits. So the city needs their blessings on making sure that we comply with all those regulations. And so then the city will actually issue the permits. And I know the city, Coopville, is actually negotiating because they don't have the staff to do the inspection, do the plant checks. So they're contracting that out. So hopefully they've gotten that to be resolved.
All the partners on this project have been very wonderful to deal with. I think one of the unusual factors that the community needs to understand is this is a small community that's used to helping build small projects. This is a very large project. So there's been a lot of steps that we've had to investigate, explain, revisit because of the complexity of this project. It's not like Oak Harbor where they build big buildings and big parking lots and worry about are the fire hydrants appropriate? Is the parking appropriate? Do you have enough handicap spaces? So there's been a lot of iterations here, and my compliments to the staff that we're dealing with, but I think that there's been a learning curve for them and they're resource short, and they've done everything in their power to help make this be as timely as they can.
We're going to have to negotiate for one's fire hydrants. So
The
that
dogs.
policy that,
The dogs.